Good day, everyone. My name's Michael Hurd with ADHD Expression. Joining me on the call is Mitzi Hollander. Is that correct?
That's right, yes.
Okay, she's joining us from South Africa. Where in South Africa are you?
I'm in Johanesburg.
Okay. Other side of the world from me here in Calgary. 15 hours difference.
Yeah, and a totally different season as well. Yeah, we're just ending summer here and going into winter, and you're just starting the new season there.
Yeah, just trying to start a new season. We had snow yesterday, and
Oh,
last week it got up to 18 degrees, and then this morning it's minus 12.
oh no, totally different. We have 30 degrees today, so it's lovely and warm here.
All right. Well, someday we hope to visit each other's countries.
Yeah, that would be wonderful, yes.
Anyways, Mitzi, she is part of the ADD lab. That's addlab.co.za or ZA.
Yeah.
And just introduce yourself a little bit. Who are you today?
Okay, I hope I'm the same person than yesterday. But Michael, thank you for the interview. I basically have been in private practice for 33 years. Got my training, my honours degree in B.Ed Educational Psychology, and has from then specialised in the field of attention deficit disorder and obviously the related comorbid activities around that. I had a huge privilege when I did my training and internship here in South Africa to do it with a neurologist who always reminded us that we could not interpret any of our psychometric assessments or psychological assessments without really having a good knowledge of the brain. So he forced us every time to say, so if this child is scoring low with block design on an intellectual assessment, how do we find that in the brain, and how would that affect that child's function? So that was kind of my, I would say, a nice kind of shift in direction for me very early in my career, and I love to integrate brain knowledge with the work that we're doing. So that basically is what I've been doing all along. I had a personal incident in my life where my ex-husband had a very serious car accident, and that then brought me into the field of brain injuries. So it broadened my spectrum a little bit. And then that's at that point where I introduced neurotherapy into South Africa and into my practice to rehab him. Little did I know that that was going to become one of the core.
Oh, we've lost a bit of static. I've lost your connection. You're kind of frozen there. Oh, there you are. You're back again.
Okay, sure.
Okay. So you were helping out your husband be rehabilitated,
Yeah.
and you brought neurotherapy to South Africa.
That's right, yes. And then basically in the field of neurotherapy, they encouraged us to rather not just work on diagnosis or symptoms, but rather use a scientific approach. And that's exactly when I then got trained in quantitative EEGs. I had to study some neurophysiology and get registered in South Africa for that so that I could broaden my scope of practice here. And then in some way, and we often wonder how our paths cross with these people in our lives, but my path crossed with a company called the Brain Resource Company in Australia. And they are basically a group of integrated neuroscientists who established an international database for brain activity. They have the biggest database in the world and the only international database. So a quantitative EEG, and I don't know if you want me to talk about that a little bit.
We'll get into that a little later in the
Okay.
interview. Just kind of laying the groundwork as far as who you are and how you got involved in the ADD world. So you're approaching things with a scientific mind, as far as understanding how the brain relates to behaviors that come from that. Am I right?
Yes, I'm integrating, I would say, the science of the brain neurophysiology with educational psychology to get a better idea of what we're dealing with. When we do an assessment, we often land up with symptoms of possible problems. If we go a little bit wider and deeper, we can actually get to the root problem, and then obviously we'll be able to diagnose more correctly, and that will determine the treatment method then of that specific child.
That's amazing stuff, because normally what I hear is some teacher or parent complains, hey, this child is disruptive and fidgety, let's see if they have ADD. They go to a psychiatrist, get assessed over an hour period of time, and then they're started given the drug regimen, whereas you say for your practice you go a level deeper than that. Am I right?
That's right, yes.
Okay, so how did your call, where'd your call come from to even get into psychological education?
I originally trained as a teacher, and I think at heart I'm still a teacher. I do a lot of training courses at my practice, and I really enjoy the teaching behind that. And we were very fortunate, or I was very fortunate to get a bursary from the government at the time that I finished my teaching degree here in South Africa. But I then had to work back those years, to repay them for the money that I got, and landed up at a school in Johanesburg, the Johannesburg School for Art, Ballet and Music, where I dealt with a group of children that were all square pegs in round holes, and they were all their round holes and they were all their own square pegs. And it really forced my thinking into a different paradigm. My husband often says I have an explorative mind, and I'm quite grateful for that, because having an explorative mind, one would always look at a different option in terms of how will I approach these kids. In those days, I had to teach history. And you can imagine an artist and teaching them about not the history of art, but just normal country, your country's history, was quite a challenge, but I really enjoyed that. And in that group of children, there were children that were challenged on a learning level, not on a creative or any other level. But that made it difficult for them, because in a normal school, even in a school like the school that I was teaching, they stood out, and they found it difficult to approach their work. I then started looking at things more deeply. At that stage, I was already busy studying my honors. I also have a brother that was born many years after me. We have a 17-year gap between us, and he was born at about 27 weeks, so a premature baby.
Oh, wow.
And had significant challenges in that. And obviously, being much older and looking at the pain that my parents went through, I think that must have also alerted me to the fact that surely there could be a different way of approaching that. So I think we all have our personal journey in terms of how we approach problems. Both my daughters that I have, my one daughter is also now an educational psychologist. I was just fortunate that they didn't have any of the challenges that I experience with the children around me.
Yeah, those are definitely big challenges, and it's commendable. So what was it that made you start? How did the ADD lab get started to help children with these challenges? And
again, I think it's being more explorative in terms of doing psychoeducational assessments. If you asked me this question 20 years ago, I would have said, well, if I do a psychoeducational assessment, we look at intertest scatter, we look at weaknesses and strengths, and recommendations will then be to a pediatrician, a psychiatrist, an occupational therapist, a speech therapist, or whatever we had on tap. Those are the people that we normally refer to. What I have found, and this is the sense that I have within me, is that we have in the world and in our society, we have become so busy, and parents are running around trying to solve the problem, and very often we overlook the fact as therapists that we have to empower parents to deal with the problem at home.
Yeah, very much.
Started changing my whole outlook and said, well, if I then have to empower a parent at home, don't I have to have a better integrated knowledge with what I'm dealing with, about what I'm dealing with? And obviously I have the benefit of having worked in an interdisciplinary team, and I still think that an interdisciplinary team is really very, very important. That gave me a good solid base in terms of how do I then approach the different things. What happened then is that I stumbled across quantitative EEGs that just further enhanced the educational assessment tools that we were using. And it kind of gave me a much broader base. And in time, what has happened, apart from the fact that I need to empower parents, and then obviously we need to empower the children to say, but this is a lifestyle issue. How do I incorporate what I'm living with in my daily life? We also emphasize to parents that nutrition, supplementation, and exercise are the core kind of three legs that we work with. If we don't get the results that we want, once we've introduced it in a very specific way, and we can discuss how we introduce that, then only will we start looking at an option of, well, should we not look at specific medication for this child? And then obviously we are guided in that way as well. So I work extremely closely with medical doctors, and the doctors that I work with, I have trained in the quantitative EEG. Mm-hmm. They do a fasting blood test. And we triangulate the information of the fasting blood test with that of the quantitative EEG, and then start off with personalized supplementation that will suit that specific profile of the child.
So by supplementation, you mean like things like omega-3s and other vitamins and stuff like that?
That's right. And then obviously, if we basically assess the brain, and we look at the blood results, we can then see in which frequency domains do we have a specific dysregulation. And approaching it from a scientific point of view, in quantitative EEGs, we have specific phenotypes. So we will, for example, will have a phenotype, a theta phenotype, which means when we measure that brain, there will be a lot of theta and too little beta. Research shows us that those are the children that really respond well to Ritalin and Concerta because it's dopamine based. What we have done in the work that we've been doing in the last 3.5 years of supplementation is we said, okay, if we know that dopamine is involved here, do we have a natural alternative for dopamine? And then started looking at, for example, is L-tyrosine then a good enough supplement? Does it give me enough brain activation? And if it does, what is the dosage of the supplement that I need to get this brain more activated? So that's one of the key or the cornerstones in terms of sort out the basic neurochemistry of the brain. It's like trying to get your pool blue. We have a lot of swimming pools in South Africa because of the fantastic weather that we have. It's like trying to get your pool blue, but you never check the pH balance. You try to put in all fancy products, but it still didn't get the water clear. So in any of the approaches that I have these days, we make sure that the basic balance of neurochemistry is there in the brain, but we do not do it in a chemical way. We prefer not to, unless really if our standard deviation scores are so way off that we know that this child would not cope without medication. And we approach it rather with a supplement route.
All right.
So that's one of the cornerstones of our approach.
So that seems to be a very core foundation, approaching the treatment of ADD from a scientific standpoint. And I guess you go off those standard deviations with that brain resource company in Australia with their graphs and stuff like that. So a client comes in, they get hooked up to the QEEG machine or whatever it is it's called. They get their brain scanned and see how it relates to, I guess, the big chart of everything that is out there.
Yes, When we do, perhaps I can just tell you a little bit more about our assessment. What is quite amazing about BRC is that they're a research company, so they're not necessarily a commercial company that sells off QEG machines. I was just fortunate enough to kind of land up as part of the research lab. But when we do the assessment, we look at quite a few different aspects. With the QEG cap, we're basically looking at the brain's activity level, the electrical activity on the outer layer of the cortex. What we also do is we look at body arousal. And there we're measuring more the autonomic nervous system. So we literally put a breathing band around the child's chest. We have electrodes on the tips of the fingers to measure sweat response. We have electrodes on pulse to look at heart rate and heart rate variability. And then we have electrodes on muscle to look at EMG, muscle tension. And what is quite significant with a lot of these kids is that they would present with a lot of aggression. They would be very busy, very impulsive. If we measure body arousal, we're basically finding, and obviously not with all of the children, but we're finding a huge group of these children with very high body arousal, indicating that the body tends to remain in fight and flight.
Yes.
And finds it difficult to go into rest and digest. When we then send these children to the doctors that I work with and we measure adrenal gland function, with most of these children we will find that cortisol levels are then too high or too low, which obviously will lead to its own difficulties.
Yeah, because because cortisol's that stress hormone.
Exactly. So what that basically means is immediately it starts impacting on sleep, because I need to go to bed now. These kids normally really struggle to fall asleep at night because of the huge amount of adrenaline that they have. And obviously adrenaline in itself is a stimulant. So with stimulant medication, like we have Ritalin and Concerta in South Africa, when we find such a high fight and flight response, these are the kids that will become more aggressive when they're on the medication. And then the parents can understand where it's coming from. We found that in about, I would say, 80% of the children, when we do a quantitative EEG, together with the comorbid and ADD symptoms that we're getting, that there's a very big sleep dysregulation in this population. I work closely with a neurophysiologist in our country that's been doing a sleep study at his sleep lab, Dr. Donovan Schultz, where we just looked at this group of children in terms of restless legs. You know, the kids that normally get, they complain about my stomach is sore, my head is sore, my legs are aching, please rub my legs. If we then start investigating that, there's a huge correlation with high cortisol levels. And then there's quite a disrupted sleep overnight. They have up to 30, 60 micro awakenings during the night. So they never go into deep sleep. And there are very simple devices on the market. You know, you can download an app on your iPad or on your phone which monitors sleep at night. And in a very simple way, you can start monitoring sleep. Or you get devices where you just, like a watch that you can put around your wrist. And without sending a child to a sleep lab, you can monitor whether they actually are sleeping deeply enough at night.
Yeah, that's there's some amazing tools out there that are, that people don't have to go to a special lab for. So, frankly, I'm amazed at just how quantitative you are studying these ADD cases or whatever. Because most people, it's just observational. Oh, how's the qualitative aspect of it going? So I'm very amazed that you can actually measure. Okay, they had their 30 or 50 episodes of interrupted sleep, or their brain waves are like this, or their cortisol levels are like that. It's just amazing how in depth you go into understanding the problem, and then I guess it gives you the tools to come up with a better solution and more holistic solution.
Absolutely. I just want to tell you, in terms of the quantitative EEG, we also measure ERPs, event-related potentials. And while the child has the cap on their head, we basically give the brain a visual and an auditory stimulus, It's called the go, no go, and the auditory oddball task. And obviously, if you take those words and you Google, you'll get all the research on that. But with the ERPs, we can basically measure how the brain understands this information, as well as the processing speed of this information. So in every 100 millisecond increment, we can determine where was this breakdown. Was it in the first 100 milliseconds when the brain had to orientate itself towards the response coming in, or was it on an executive level where this information just never got to the frontal cortex to actually execute the task correctly? So processing speed in the population of attention deficit disorder is quite detrimental. And in terms of processing speed, immediately that will affect the working memory of this child. And if I just practice memory task, is that going to be then sufficient to speed up a working memory? Not quite so. Again, we have basic neurotransmitters that we will look at and basic brain pathways that we need to retrain to get the information to be more effective. Just to tell you as well, we also do a continuous performance task during the QEEG assessment, where over 8 minutes we measure concentration. We also do a maze, which is an executive function task, looking at the frontal cortex, because ADD is an executive dysfunction, to see on a neurocognitive level what are the challenges in terms of execution of tasks. I can just mention to you something again that's quite significant, is that when you have children with high body arousal where they are constantly in fight and flight, the limbic system that kicks in basically goes and it overrides the frontal cortex, which then impacts immediately on executive function. And those are the kids that literally just freeze up when they need to execute a task. So sometimes the execution of task is due to the anxiety and not specifically because there is an executive dysfunction.
No, of course not.
And we also do an emotional battery in that assessment where we look at resilience, we look at motivation, depression, anxiety, and stress. And in the end, we need to dovetail the information from that assessment to see how does it fit into a bigger picture. So you can't, in any assessment, we can't just take one component and highlight that and say this is the specific problem. One actually needs to integrate it into an entire picture. And that's basically, I would say, in the last 7 years that I've been doing quantitative EEGs, it's brought about a huge shift in my practice in terms of, so how am I going to approach this? Something that's really interesting, and you have to stop me, you see, I get all excited when I start chatting about something that's really interesting that we also measure in the quantitative EEG is something that we call asymmetry. So we basically measure how the right and the left side of the brain is communicating with each other. And if you pick up a significant asymmetry in children, those are also the children where that score or that result will correlate with a score in your intellectual assessment, where you would find quite a big discrepancy between the verbal and non-verbal subscale intellectual assessment. If you look at your occupational therapist's report results, they will often refer to it as a bilateral integration difficulty. So in essence, if the brain does not integrate the information right and left, information just takes that much longer to get processed. And again, this is where the challenge lies within a classroom situation with time limits for a child with an attention deficit disorder. And obviously, if one can point this out to parents very specifically, they almost become relieved. I often say to them, I'm going to take you on a tour through your child's brain so that you can understand the behavior in terms of where it's coming from. I think a lot of the parents, and you may concur with that, very often as parents, and I'm a mom myself, if something goes wrong with my children, anything bad happens, the first thing I'll ask myself is, oh my golly, what did I do that was wrong? And very often if parents start understanding in terms of how the brain is processing, that is quite powerful knowledge to say to them, so if I have brain processing in a certain way, what can I as a parent do to make sure that the learning environment is created in such a way that it will optimize learning at home, and then obviously with the help of the school, to optimize learning for the specific
and
child.
this comes as far as empowering the parents and empowering the child.
Absolutely. If we look at the neurophysiology, and I'm going to oversimplify how learning takes place in the brain, but very often we have to start oversimplifying things before we actually truly understand how we need to go about this. When a child needs to learn, the brain first needs to filter the incoming information through the senses, through the eyes, through the ears, through touch, through smell. Occupational therapists call that sensory integration. And with many children, if we start looking at the quantitative EEG, already on a filtering level, things go wrong. And that filtering, I love to use the analogy of a net that we have around us. And the net lets in what's relevant, and it keeps out what's irrelevant. And with a lot of our kids with challenges, at that very first level, in terms of how do I filter information properly from our environment, already things go wrong there.
Yeah.
Very often, in terms of, if we then look at a sensory integration profile, which is really important because the profile again gives you an indication of what the sensory integration diet needs to be for these specific children, so that we can create that learning environment at home. If we look at that profile, again, we need to look at the underlying neurotransmitters. So what I'm seeing in the practice, and I haven't done the research or seen the research on that yet, so this is just an hypothesis, is that very often on if we look at brainwave frequencies, in terms of alpha rhythm, alpha is my idling state of my brain. It puts my brain into a restful mode and gives the brain the chance to integrate information. Very often in that alpha state or alpha brainwave frequencies, we will pick up brainwave dysregulation. Underlying that, one of the main neurotransmitters that will drive alpha is, for example, serotonin. One of them. There are plenty. So, for example, if we then do a fasting blood test and we look at serotonin and we correlate that with the QEG, if we then provide the parents with a serotonin supplement, it does. I had parents in here this morning where the young boy said, he's 11, he says, "Mom, I'm sitting in class, and I don't know, but it seems like I'm starting to understand things a little bit better." He obviously cannot say, "Well, I'm filtering better and I'm getting the essential detail and so on," but it does play a significant role. And again, we can't just go and look at a sensory profile and not look at the underlying neurochemistry and address it at that level. I find that there's a lot of children. There's a balance here in terms of, is this ADD, ADHD, or is this a sensory integration dysregulation? And yes, sensory integration is definitely a comorbidity of attention deficit disorder. But you get children, like one of the children this morning, with difficulty, but it will present like an attention deficit disorder because of the symptoms.
So let's take a step back and walk me through who are your clients and how long does this process assessment usually take, and going forward, are you bringing them back in for reassessments as they progress through I guess their schooling, and do you work with adults as well?
Yes, we do work with adults, and the practice, the core business of the practice is attention deficit disorder. Because of my life's journey in terms of rehab with brain damage, we do get children with minimal brain trauma, near drowning, where I get some stroke patients that we work with every now. Core practice still is attention deficit disorder. We work with teenagers, but I would say if I had to look at a breakdown of ages, basically from the age of 6 to about 12 years old, I would say that's mostly the children that land up at the practice. The kind of client that comes to the practice are parents that's done the journey. They have gone through all the routes. They've tried different medications. They've tried different therapies. And at the end, they say, we don't know what's happening here, but we're not seeing the progress. In terms of the effort that we've put in, we're actually not seeing the results at the end of the day. So unfortunately, we're still in a position where we almost become the last resort.
Yeah, that's what it seemed like.
I would love to see it as the first port of call. And then obviously the other clientele are basically the parents that's decided not to do the chemical route at all and decided to just do the wellness route in terms of nutrition, supplementation, and exercise. So those are the people that come. QEEG assessment, I still do psychoeducational assessments. You just need to know that, and a lot of school readiness screening assessments. But when we do a quantitative EEG, we work about, the assessment is about 2 hours. The setup of the test has to be quite accurate. I'm very closely monitored by the Brain Resource Company in Australia to make sure that the quality of the work is good. If it's not good enough, they'll send it back and say, you better redo that. So I have the big boss looking over my shoulder the whole time. After we've done that assessment, we send the information through to Australia. It takes about 10 days for us to get that information back. And then the raw EEG results go to our neurophysiologist, and he basically interprets that EEG in the way that a neurologist will interpret that, looking for any hard neurological signs. Is there something like epilepsy or something that a neurologist need to look at? He then writes a report, and I basically walk through the statistical process with the parents with the quantitative EEGs. Our first recommendation normally would then be to have the fasting blood test. We've just decided that approaching it in a scientific manner is going to be better. It's very easy for parents to go into, I don't know, if you have it there, I'm sure you have, because we have this in Africa, where you have this rows and rows of supplements on a shelf.
Yeah.
And parents has this huge variety that they can choose from. We don't always know whether all the products have NAPI codes, what if they're correctly registered. Can children use the product? So those are the questions that we've also asked ourselves when we started looking at the market of supplements, is if we are using a scientific approach, we have to maintain the science behind it and not just take any product and say, okay, take this product. So most of the products that we use in South Africa are actually imported from Australia and from the States. It does make it quite expensive, but it works really very well. Very often then when we do ERPs, and this is how I landed up in the field of the Tomatis therapy. In a lot of these children that we work with, we get auditory processing difficulties and auditory integration difficulties. And when we measure the ER, it's already at a receptive level where information is not registered correctly.
Yeah.
So the ears can hear, but the child isn't actually listening. And that's exactly the research that Dr. Tomatis did. And I don't know.
Oh, we had another audio blip. Hopefully we'll be coming back to you. Just it seems frozen. Oh, all right. So you're talking about Dr. Tomatis.
I don't know if you are aware of the work that he did. He was an ear throat specialist in France. He did a lot of research. And he basically said, if I do a normal audiology on the children in the spectrum, they can hear, but it's very clear that they're not listening. And he developed a listening test, and the calibration is slightly different than to that of an audiometry test or an audiology test. And from there, he started developing music programs. Fortunate that his dad was an opera singer in Paris, and he used Mozart's violin concertos and started manipulating the music. There's a huge amount of technical knowledge involved with this, and I call myself a baby Tomatis provider. I've only for 4 years now. There are amazing people in the world that does that. But looking at the ERPs, the auditory ERPs, these were children in the practice that I tested where the parents have said, but we've done speech therapy for 2 years and we didn't quite see the results. And remember, these are the extreme cases I'm talking about. We have amazing therapists in the country. They really do fantastic work in speech therapy and occupational therapy. I'm talking about the cases where we are really challenged, where we're not seeing the progress that we are expecting. I then did my training in South Africa. We also had Professor Wynand du Plessis at one of our universities who did research in Tomatis for 20 years. Unfortunately, Professor du Plessis passed away last year, but in this short time he became a bit of a mentor for myself. And I just realized that this was a market or a modality that I've overlooked entirely in the 33 years in my practice, when I started realizing what a huge impact listening had on the processing and speed of processing of information in the brain. So I have to tell you, we get amazing results with the Tomatis therapy in terms of integration. So that's definitely one of the modalities that we use of treatment. And obviously, very close to my heart is neurotherapy.
Of course. That's how you got started.
I did my training in Los Angeles at that stage with a company called EEG Spectrum. They are a really good educational group of people that's put training material together, registered with the Psychological Association in America. And basically with the neurotherapy, obviously I came back to South Africa. You know, I was born before technology. I'm that generation. So for me to just get a laptop and kind of open it up and then, you know, let alone putting on all the EEG stuff that I needed for the neurotherapy, that was quite significant for me. And obviously did a lot with my ex-husband with tremendous results. Just excuse me, I just need some water.
Okay.
And then slowly, again, with the help of amazing mentors in the United States, got myself settled in the field of neurotherapy. Sorry.
There we go. Get your voice back.
Any questions?
Well, so you've got these three, I guess, quantitative models: the QEEG, the Tomatis, and then the neurotherapy that are the solutions that you offer to parents. So I take it your clientele has to be local to South Africa, am I right? Your microphone isn't all the way on. I can't hear you. There you go.
Sorry. Train now in the field and quantitative.
You're still breaking up. Okay, let's try again. Okay.
Sure. Can you hear me now?
I can hear you perfectly now.
Okay. Yeah, I obviously work mainly with children within the immediate environment or vicinity where I have my practice. But fortunately, there's a lot of therapists trained all over the world in quantitative EEGs and neurotherapy. So there's quite a broad international base and availability to parents in quite a big way. I would say the big drawback is that it's not available to parents where financially and economically they cannot afford things like this. It's quite an expensive therapy still. We're only getting the we call it the medical aid. I think you call it the health insurance. The health insurance is only starting now to reimburse parents for this in South Africa. I know that in the United States, they've been doing it for quite a while already. So it would be fantastic if we could bring it up, in a broader sense into schools, where the schools will basically pay a salary to a neurotherapist and say, okay, please come into the school and work here on a permanent basis. That will give us more availability for the children in schools then.
It would, because definitely for me with a scientific mind as well, I find, okay, let's define the problem. Let's get these measurements, and that's what school's all about. Hey, let's how do they score on this test and that test, and figure out how things go from there. Because especially with ADD, often criticism of going the chemical route is these doctors don't know what's going on in the minds of the children or the adults, what these chemicals are going to do to them. They just observe the actions. Oh, gee, they're less fidgety and they're less moody. It must be working.
Yeah, and again, I'm saying to you that if we look at the phenotypes in quantitative EEGs, there are specific phenotypes that will really respond well to medication. But then you get the children where there's such a lot of dysregulation all over the frequency bands that they don't necessarily respond well to one specific medication. I'm sure if we could have this interview in 20 years' time, we're going to have something like nanomedication where you the tablet and say, just go to the frontal cortex and give us a little bit more dopamine there, but please don't affect the rest of the brain. I think that's going to come, but at this stage, unfortunately, it will impact the entire brain. And some of these kids really just have very negative side effects, in terms of almost the sense of self is not there anymore. And the children often, if they have an overdosage of medication, specific medication, they will say, it feels like I'm not in my body.
Yeah.
It feels like I'm drifting outside my body. And we don't always, and when we did the sleep research with the neurophysiologist, my colleague, he says, what's wrong with all of this is we don't know what the right questions are that we need to ask. We have our standard scientific questions when we speak to the children, but we actually need to make more time to formulate the questions in terms of the information that they're giving us, and we will be able to get more information from the children. I just want to say to you that just want to come back to the bilateral integration, the right-left disconnect that we see. With the children where we get this disconnect, these are children that when we do therapy, movement therapy, for the time that they are doing therapy, we normally see good results. As soon as therapy is terminated, you see a regression in terms of integration. And one of my assumptions, and sometimes my colleagues get a bit uncomfortable with me, is that we have assumed for many years that if a child, and there are some children who cope well with that, but there are children in this population of ADDers where bilateral integration again is a lifestyle issue. It's not go to the therapist twice a week and we're going to solve that. And unfortunately in South Africa, we don't have included into our schooling anymore physical education periods. So children are only given the informal opportunity to run and play during break, but there's no formal input in the schooling system in terms of movement.
Really?
I work, hence the fact that we're really short of Olympic athletes. So hopefully in 20 years' time, the profile will be a little bit different. But in the schools, when we do a full assessment like this or a quantitative assessment like this, one of my functions, and I do not charge parents for this, is that I go to schools and we sit with the entire team of people at the school, whether it's the head of department, the teacher, the occupational therapist, the speech therapist, whoever is involved in this child's therapy. And we go through the program and then come with practical solutions in terms of everyday activities that enhance what we see. I have a school here, a fantastic little private school on a river, a beautiful little school, where I said to the teacher last year, I said, the children in your classroom every morning every child comes from his own unique environment. And 10 minutes 10 minutes of just talking, and then immediately you start off with a lesson, mathematics. I said 10 minutes is not sufficient to get those kids properly regulated, whether they're on medication or not, just to say, I am here. Arousal such a stage that I can engage. And I said, if we look at how many of our children are now dealing with bilateral integration difficulties, we don't have to introduce a formal program, and there are amazing formal programs. Again, in Australia, they have a program called Learn to Move and Move to Learn, and we have you just bring in running around the soccer field a few times before I move my children towards the classroom. That in itself is going to start helping the brain to integrate information from both sides of the body. And if we don't do it on a body level, which is a concrete level, we cannot even dream or expect more abstract concepts to be integrated at a higher level.
Of course.
So I'm getting amazing results through exercising with their children.
Yeah, just little steps. All right, we're coming to the end of the time we have for this interview. Any final bits of advice you'd have for the global audience, and then in the end, how do people who wish to work with you, how do they get a hold of you and learn more about this?
People can definitely email, and there are definitely people that work with quantitative EEGs as well. Can you hear me, Michael?
I can hear you now. You keep on going in and out, but now I can hear you.
Okay. I think very important for parents is to get as much information as possible, and they themselves need to be able to filter information properly. The basics is very important, and still I'm going to say that if the basic neurochemistry isn't properly sorted, it's trying to get your pool blue again, and you haven't checked the pH balance. Nutrition, extremely important. And then, as I said, exercise. I think it's really important that parents need to ask questions to say, what tool can you give me? How can you empower me so that I know that if I have a sleep problem with my child, I need to look at sleep hygiene, and I need to create an external rhythm of sleep, circadian rhythm, and how do I go about that at home? So I think that's the moral of the story is parents need to ask the questions in terms of, so what can I do at home that help, and not leave it as a responsibility. And unfortunately, that is what money does, is we get money and we pay and absolutely believe that therapist is going to solve the problem. I think that's the wrong position.
Yeah.
Be one of the core questions that parents need to ask is, what can I do? How can you empower me so that my child can truly understand what he is going through? And I absolutely believe that we need to be honest with parents. I cannot treat a child in my practice that's epileptic, and the parents keep on telling me, please don't tell the child that it's epilepsy, just tell the child that they're really fainting. I'm never going to, I know, I have that. So the prognosis is just so poor when you have that. And, research shows that if a mom, and she fully understands what's going on, and that mom has a good support structure, again, your prognosis is...
Okay. Are you still there?
Yes, I am.
Okay, good. All right, so definitely get as much information as possible, get the basics for the chemistry, good nutrition, exercise, and just always asking, how can I create a home environment that will help my child?
And obviously working with all therapists involved, really important.
Yeah, working with everyone on the team. So thank you very much, Mitzi, for your time, and it's amazing to see how global the effort is in helping people with ADD empower themselves.
And thank you for the opportunity.
All right. Have a good day. This is Michael Hurd signing off with ADHD Expression, and my guest Mitzi Hollander from Johanesburg, South Africa.
Bye-bye.
Bye.